Case scenario: you are a pediatric intensive care unit, PICU, resident on duty. A 5-year-old child, Alex, is admitted with septic shock and coagulopathy. The child's laboratory results show the attending physician asks you whether a plasma transfusion is necessary.
Question 1. What should be the first step in evaluating Alex's need for a plasma? A. Administer fresh frozen plasma, FFP, immediately. B. Assess the presence of active bleeding or planned invasive procedure. C. Transfuse platelet concentrate along with plasma. D. Order an immediate thromboelastography.
Correct answer. B. Assess the presence of active bleeding or planned invasive procedure. Plasma transfusion is primarily used to prevent or treat bleeding. Studies suggest that mild to moderate prolongation of INR or PT does not correlate with bleeding risk. In non-bleeding patients, plasma transfusions should generally be avoided, unless preparing for surgery or an invasive procedure with a high risk of bleeding.
Alex is currently not actively bleeding, but the surgical team plans to place a central venous catheter, CVC, for continued resuscitation. The attending asks whether plasma transfusion is indicated in preparation for the procedure. Alex is currently not actively bleeding, but the surgical team plans to place a central venous catheter, CVC, for continued resuscitation. The attending asks whether plasma transfusion is indicated in preparation for the procedure.
Question 2. Should you transfuse plasma before the CVC placement? A. Yes, because the INR is elevated and there is a risk of bleeding. B. No, because INR at 2.0 does not warrant plasma transfusion in non-bleeding patients. C. Yes, but only if the INR is greater than 1.5. D. No, because plasma transfusion does not correct coagulation defects reliably.
Correct answer. B. No, because INR 2.0 does not warrant plasma transfusion in non-bleeding patients. Plasma transfusion is not routinely recommended for INR 2.0 before procedures. Observational studies suggest that prophylactic plasma transfusion often does not correct mild coagulation abnormalities. If INR is 2.0, plasma transfusion can be considered before high-risk procedures.
The CVC is placed without complications. However, 12 hours later, Alex develops active gastrointestinal bleeding. The repeat lab results show
Question 3. What is the best management approach? A. Transfuse plasma immediately and recheck INR after 1 hour. B. Order thromboelastography, TG, before making a decision. C. Administer cryoprecipitate instead of plasma. D. Observe and only transfuse if the INR reaches 3.0.
Correct answer. A. Transfuse plasma immediately and recheck INR after 1 hour. Active bleeding with an INR from 2.0 is an indication for plasma transfusion. In massive bleeding situations, plasma should be transfused before standard coagulation test results become available. Thromboelastography, TEG, is useful but not essential in an urgent scenario.
you decide to order plasma. The blood bank asks which type of plasma you want to use.
Question 4. Which plasma product is the most appropriate for this patient? A. Fresh frozen plasma, FFP. B. Solvent-ash detergent plasma, SD plasma. C. Thawed plasma stored for 5 days. D. Frozen plasma, FP24.
Correct answer. A. Fresh frozen plasma, FFP. FFP is the standard plasma product used for coagulation factor replacement. SID plasma has improved safety regarding pathogen transmission, but it has reduced levels of protein S and plasmin inhibitor, potentially increasing thrombotic risk. Thawed plasma stored for 5 days may have reduced coagulation factor levels. Frozen plasma, FP24, has lower levels of some clotting factors compared to FFP.
Case conclusion. Alex receives 10 ml of FFP and bleeding improves. Follow-up labs show INR equals 1.7, APTT equals 45 sec, and stable hemoglobin levels. Key takeaways. Plasma transfusion should be based on clinical bleeding risk, not just coagulation tests. Prophylactic plasma transfusion is not recommended in non-bleeding critically ill children unless preparing for a high-risk procedure with INR 2.0. In massive bleeding, plasma should be transfused before lab results are available. FFP is the standard plasma product, but SD plasma may be preferred in certain situations. Always reassess coagulation status after transfusion to avoid unnecessary plasma administration.